but she and I could both tell you stories of people that come in too late for their problems. That come into their orthopedic surgeon, to their general practitioner with severe problems in their feet or in their leg. What often happens in the diabetic population is that since this is expensive, they're going to have to pay out of their pocket. The insurance company, Medicaid, doesn't pay for them. They come in late. And I would just relate a quick story here. I had a patient who was a diabetic, which is the most common people with problems in the foot area. He had very poor feeling in his feet, which is very common in the diabetic population. He liked to read a book every night before he went to bed. He had his magnifying glass, reading just fine, took his magnifying glass, set it to the side of his bed. Well, where he set that was in his slipper. When he got up in the morning, he put on his slipper. He could not feel the magnifying glass in his slipper. Consequently, he wore it for several hours and didn't know it was there. It rubbed a sore in his foot. Didn't hurt because he couldn't feel it. The sore developed, became infected, became gangrenous, and eventually he noticed a foul odor as the first thing that he noticed. He smelled something bad going on, looked at his foot and said, "Oh my gosh, there's something wrong." Went in to see a general practitioner because that was the only one that would be paid for. They treated with an antibiotic, et cetera, et cetera. That gangrene eventually worked itself up the foot. It was very developed by the time he came in. Long story short is that this gentleman ended up losing his foot initially. Down the road, ended up losing the bottom half of his leg from the knee down. Unfortunately, in a lot of cases, this ends up with the person not surviving. It's a fairly common consequence. One of the intents of this bill is to perhaps prevent that from happening. Some of the folks that speak to this bill talk a little bit more about that. But I think it's important that we get the podiatrist on there so people can go to the podiatrist rather than wait that lengthy time to get into a practitioner. You've heard sometimes a 2 or 3 longer week wait to get in to see them, or even longer to get into an orthopedic surgeon. That being the case, we'd like to get them on the list where people can get in and see the podiatrist, have it paid for, and have effective care and perhaps save a life or a foot or whatever that may be. But I think podiatrists are important to include on this list. And that's the essence of the bill. The bill's not much more complicated than that. We insert podiatrists onto that list of considered providers. And at some point, hopefully soon, we're at the end of that list and we don't have to add any more to these. But I think podiatry is one that's been overlooked. And we need to get added on. With that, I would stand for any questions.
Questions for Chairman Baldwin? Not seeing it yet. Thank you. And if you need to run back to your committee, I can text you that you're good. We are a lot more fun. Representative Botman, you're not here for this bill, right? No. All right. Governor's office, podiatry, not that one either. Hospital Association. Anybody here to talk about feet today? AARP. Come on down, Mr. Laycock. Welcome, Mr. Laycock.
Thank you, Chairman Zwanitzer and committee. My name is Tom Laycock. I represent AARP Wyoming and our 83,000 members in the Cowboy State. We would like to express our support for this bill. AARP believes states should allow professionals to provide services to the full extent of their current knowledge, training, experience, and skills where evidence indicates services can be delivered safely and effectively. Podiatrists play an important role that perhaps isn't always top of mind for some, especially when it comes to treating chronic diseases, especially diabetes. Older adults have a connection to Medicaid, and that older adults who reach a financial threshold and require long-term care can have that care provided through the Medicaid program. Allowing Medicaid to provide podiatrists for that care would allow for more access to care, especially for those with diabetes. We know the majority of diabetic amputations are preventable. We know there's a major cost to amputations in both quality of life as well as those who pay for such procedures, including the state. Those numbers are well documented in a study conducted in Arizona that found after the legislature eliminated Medicaid coverage for podiatry services, the state saw worse patient care in terms of increased inpatient admissions, length of stay, and severe outcomes. In short, better access to podiatry care would result in better quality of life for our citizens, potential savings for the state of Wyoming where diabetic patients on Medicaid are concerned. Those seem like compelling reasons for us to move the bill forward, and we thank you for your time. Happy to stand for questions.
Questions for AARP? Representative O'Hearn.
Thank you, Mr. Chairman. Did I hear that we used to provide podiatry care and we don't anymore?
Mr. Chairman,
Like-
that was actually a study that was done in Arizona where they used to provide podiatry care and do not anymore.
Other questions? Saying none. Thank you. Anyone else here to text or testify on Senate File 37? Not very, okay. Senator Baldwin, maybe you could just talk to the committee quickly. There was an appropriation in the bill in your body, which came out for $56,000, which would be half of what the department, I believe, was quoted saying that it would cost to meet the per member per month enrollee. Any discussion on why that came out? I mean, I can guess, but I'd like to hear it from you.
You can guess. That came out because after a rather lengthy discussion in committee, not lengthy, but a discussion in committee about actually that felt they could probably absorb the cost, number one. Number two is because of the cost savings, was a realization that probably there would be an ultimate cost savings if these folks would actually go, and they based those numbers on the number of Medicare patients actually that they'd seen, and not Medicaid patients, but the Medicare patients. And they assumed a number of those would be Medicaid, or the percentage of those would be Medicaid patients that would come in. And after looking at that number, if they felt they could absorb that number, but the cost savings would justify it because they would actually be more cost savings than expenditures.
And maybe just another question in general, if you know, do we start listing all types of providers of medical care? I mean, it just surprises me a little bit that we don't cover podiatrists somewhere else in the general practice of medicine with Medicaid reimbursements. And so, I mean, do we specifically go specialty by specialty and, I mean, decide on dermatologists or ophthalmologists next?
Interestingly enough, a number of those are already covered under the Medicaid. And this is only, and those who have been on the legislature for a while, I guess that's you and me. But we end up going back in a lot of these things, including things that we left off. They have their own practice act. They have their own, they have a board that overviews them, as do all those that you just mentioned, optometry, et cetera. As far as being on the list of, and I don't have the statutes in front of me, but I think we're nearing having most of those medical providers. And there is a definition in the statutes of what is a medical provider, what is a provider. And I think we've almost got that covered now, if not fully covered.
This does
But
look to
every year
be
somebody finds something new.
our 37th that we're putting in this chapter. All right, any other questions? We'll close public comment committee. What's your pleasure on Senate File? We do. Great, bring them in. Welcome, Ms. Kemp. Floor
Hi.
is yours.
Thank you. Sorry, there's a bit of delay. My name is Carissa Kemp, and I'm the Director of State Government Affairs for the American Diabetes Association. Thank you, Chairman Zwanitzer and committee members for allowing me the opportunity to testify in support of Senate Bill 37 this morning. The bill to add podiatry coverage for Medicaid is critical for people with diabetes. Diabetes can cause nerve damage and reduce circulation, which can lead to limb loss and other complications. Additionally, people with diabetes may develop something called diabetic foot ulcers. When left untreated, these ulcers can become a portal for infection, with more than half of them leading to higher rates of ER visits, hospitalizations, and amputations. Podiatrists are specifically trained to assess the nerve damage in feet, identify foot health risks, and help create a plan to reduce the risk of complications. This bill and the timing of it is particularly important because amputations are actually on the rise in the United States. Just last year, there were over 154,000 diabetes-related amputations. It's the single greatest factor in amputations, with more than 60% of amputations occurring in the diabetes population. And actually 85% are preventable. So how can we prevent them? By checking feet daily, going to regular doctor visits, and wearing proper footwear, we can reduce the risk of amputations. Simply put, having access to podiatry services is critical for this population. And seeing a podiatrist specifically and being treated by one can reduce the risk of hospitalizations by 24%. As some others talked about, there was a study done in Arizona after the legislature eliminated Medicaid coverage. They were hoping it would create cost savings, but it actually did the opposite. So they found that for every $1 that they hope to save in the Medicaid program, it actually resulted in an increase of $44. And in addition, the state experienced a 37.5% increase in diabetic foot infection hospital admissions, longer lengths of patient stays, and nearly a 50% increase in severe aggregate outcomes. So according to Wyoming hospital discharge data that we have available from July 2020 to June 2021, there were about 253 patients discharged from Wyoming hospitals that had both a diagnosis for diabetes and also a diagnosis for a lower extremity amputation. That doesn't mean that the amputation occurred during that specific visit, but they were in the hospital for at least one night stay related to these two issues. And the total charges for those 253 patients for that year was nearly $14 million. By passing this bill, Wyoming can improve patient outcomes and save costs by reducing the risk of amputations, hospitalizations, and even deaths. As Senator Baldwin referenced, we know that after getting amputation, it can greatly reduce your life expectancy. And I just want to share that during the Senate hearing, we did have some Wyoming podiatrists speak in support of this bill. I spoke to some yesterday who had some patients they had to see this morning and were unable to make it, but I've heard from several of them that really stand in support of this legislation. So I appreciate your time and urge your support.
Thank you. Questions for Ms. Kemp? Not seeing any. Have a most excellent day. All right. Nobody else on the Zoom world? With that, we'll close public comment. Moved by Representative Ahern, seconded by Representative Chadwick. Representative Yen.
Mr. Chairman, maybe just a procedural question. So as Senator Baldwin knows, there are two bills that have the same subsection number 37. Is there, what happens if both bills pass, and should we pick a different number?
Senator, we have had that before, and I know we've had to hold one to make sure, and then we amend. I don't know if that magically happened and it just bumps down the list of some other law goes into effect first or not. Do you?
I think this, Mr. Chairman, I think they stand independent. I think you can pass one, not the other, et cetera. I don't think it makes any difference. I think the one passing doesn't affect the other one.
Go ahead, Representative Yen.
So, Mr. Chairman, Senator, the question I'm asking is if we pass both of them and they both say subsection 37, which one is subsection 37 and should we number 138?
I think that would be up to the department. I think that's just a procedural thing, and I think it would be a technical issue.
I think we should ask LSO in case the bill passes, if we need to renumber it on the floor. Representative Yen.
Mr. Chairman, then I'll just make the motion, and if LSO says we don't need it, then we can just withdraw the standing committee amendment. I'll motion to make this Romanet 38 instead of 37.
Second.
Okay, that's the motion on the floor that as pharmacy 37, is that is that the other bill? Okay. Any discussion on that committee? It's probably a good catch. I don't know if it happens automatically, but one more concurrence for the Senate to do. All those in favor of the amendment, say aye.
Aye.
Opposed, say no. Yeah, that amendment passes. Other discussion or amendments on the bill? Representative Ward.
Thank you, Mr. Chairman. So I view this as an expansion of Medicaid, which you'll not be surprised to find out I don't believe is the role of government. So I will be voting no.
Other discussion? Representative Clouston.
Thank you, Mr. Chair. So someone who's done a ton of diabetic care and wound care and fitting prosthetic legs, especially when I worked on the reservation in North Dakota, I could see where this could really maybe help save some people and save some money in the long term. So the stats from the Diabetic Association were really helpful.
Other discussion amendments? Seeing none and question being called. Marilyn, if you call the roll on Senate File 37.
Representative Chadwick.
Aye.
Representative Clouston.
Aye.
Representative Harnok.
No.
Representative Ahern.
Aye.
Representative Penn gave an absentee vote of no. Representative Trujillo.
Aye.
Representative Ward.
No.
Representative Yen.
Aye.
Chairman Zwanitzer. The bill passes 6 ayes, 3 noes.
And because my name's on it, I believe I'll be hearing that for you, Senator. So we'll talk if anything needs to happen. Bye, department. All right, with that, we're gonna go to Senate File 79, Plan of Safe Care Newborns. So you all were here for that bill. You just didn't want to testify is what I'm gathering. Okay. Got it? Bye, Greg. Bye, Jesse. We'll give the room about 20 seconds to clear out here. All right, welcome back, Senator Baldwin, Senate File 79, Plan of Safe Care Newborns. Been a hot topic on my email all weekend for a bill that hasn't had a single vote against it yet. But you talk about Senate File 79.
Thank you very much, Mr. Chairman. This bill is born out of a concept that actually came up last year. Those of you that were here last year, actually, it's been in existence longer than that, but you'll recall we had a bill addressing newborns and those who were born into drug type families where mom had a drug problem or an addiction problem. That bill focused on criminal penalties towards the mom. And that bill had a number of issues. And I'm sure you received a lot more emails about that than you did about this one, but ultimately that bill failed because it was this feeling of the bodies and the feeling of most folks that we would actually discourage those people from coming forward to get prenatal health because there would be penalties involved and in some ways, I believe felonization in one case. Regardless, that bill didn't make it all the way through. This bill comes from a different angle. This bill has no criminal penalties. This bill doesn't concern any of that. What this bill does is it's trying to set up exactly what the title says, Plan of Safe Care for newborns. But I would tell you that it goes one step beyond that, beyond just the newborns and the prenatal. It plans for something for a mom, for the drug addicted mother, and trying to get her into some safe care as well as the newborn. And as I saw when I was driving into Cheyenne last night, one of the billboards said, protect our babies. And I think that pretty much summarizes what this bill does. We want to protect our babies. I don't believe that that's what that billboard, they didn't know anything about this bill. But I think that pretty much talks about what we're doing here, just quickly working through, because I know there's others who want to talk to this bill. Just working our way through definitions, it's talking about what the plan of safe care is, a plan designed to ensure the safety and well-being of an infant with, and this is something that was added in my committee with prenatal substance use and prenatally as well as after they're born. And the prenatally part was added into this bill, which I believe is probably a very good addition. But trying to improve the health of the infant following the infant's release from the care of a healthcare provider by addressing the health and substance abuse treatment needs of the infant and the affected family or caregiver. And just quickly working through the bill, it talks more about the ideation of the bill, ensuring the safety and well-being of the infant. Talks about the way that this will actually happen. If you get down on the bottom of page 3, down line 19, we start talking about the plan of safe care, talking about whether this occurred as a result of medication-assisted treatment or medication prescribed. And that being, maybe the mom was on pain relievers. Maybe the mom received some medication actually in the delivery process that causes a problem with the baby. So this bill addresses that, as well as the mom that comes in with meth addiction or heroin addiction, or whatever that addiction might be. So we thought that was an important thing to include. It includes prescribed medication as well as those that are used outside of the legal system. And then we look at whether the infant's mother is or will be actively engaged in ongoing substance use disorder treatment that might mitigate the future risk of harm to the infant following discharge. And then following through on the remainder of that page, it talks more about what the safe plan of care is, who will set that up, talking about community partners. And I say some of these folks behind me will talk about that more in depth. Some of these, there is a pilot program set up that's already working something towards this. They can talk about that. And then in line 11, it talks about the patient care team shall report the total number of infants and family for whom a plan of safe care has been developed to the Department of Family Services. And then it gives you the statute where that report will come in. And then what happens if that team identifies a safety concern for the infant? What happens in that case? And finally, the one change that we made over on the Senate side, I believe it was on page 2, talking about, let's see, on line 10, starting to double little I, patient care team means a team of healthcare providers, including one or more licensed healthcare providers. Initially that it said licensed physicians. In the statutes, it's very clear, the group of providers includes advanced practice nurses, PAs. It includes a number of things besides just physicians. So to make it consistent with the statutes, we changed that to say a more licensed healthcare providers. And so with that in mind, I say the bill defines what that plan of safe care is. And like I say, the intent of this bill is to provide an avenue forward for those infants and for the mothers. It doesn't involve criminalization, doesn't involve any felonies, et cetera, just getting the care out there. We want to be concerned about what happens with those babies once they're born. And we want to make sure that they're taken care of. And that's the intent of this bill, is to move those babies forward and keep our babies safe, quite frankly. I would stand for questions.
Questions, Representative Ward?
Thank you, Mr. Chairman. How are these babies' families identified? Babies and families?
Go ahead, Senator Baldwin.
Yeah, and this is to be identified by the provider. Number one, initially the concept was maybe the provider, doctor, midwife, whoever that delivered the baby. And a realization was made, sometimes that happens outside of the hospital setting. So it may be when this infant's brought into the ER, it may be when they're brought to a general practitioner because they've got a cough or a runny nose, that realization is made. Ultimately, the identification has to be made by that healthcare provider, whoever sees that infant. And I don't remember in the bill where it says that, but that's where the decision is to be made, is by the healthcare provider.
Go ahead, Representative Ward.
Thank you, Mr. Chairman. So the decision does not include the parents?
Go ahead. Senator Baldwin, but it might be in the top of page 3.
Thank you, Mr. Chairman. The decision to make a plan of healthcare does include the parents. And I'd have to read through the bill again, but the parents are included as part of the team when this plan of safe care is admitted. And actually, again, one of these folks from DFS can talk with you, can tell you exactly, but they are included in the team and in the planners for that plan of safe care.
Do you know if we define infant in statute, what that age is? When we say an infant?
Can't tell you, but I suspect somebody behind me can tell you.
Thanks. Representative Klauston, did you have a question? Oh,
You can come back to it.
I'll come back to you, Representative Klauston. We'll go back to Representative Ward.
Thank you, Mr. Chair. Two quick questions. Is this program only for Medicaid families?
Senator Baldwin.
Mr. Chairman, no, this program is for all, for anyone that we find an infant has a problem.
Okay, so that may answer Mr. Chair, my second question was just how our postpartum bill covering moms for a year now would correlate with this, but it sounds like as it's an expanded program, it would not just be those Medicaid moms.
No. Which interestingly, I'm hearing this week as well, that bill.
All right, Representative Ward.
Thank you, Mr. Chairman. Are all moms and babies to be alcohol/drug tested here?
No, Mr.
Baldwin.
Chairman, that was a concern. And no, unless there's an indication, unless there's some reason to cause suspicion or some indication, no, everyone will not be tested. We felt that was important because it would be an infringement on rights to test everybody, quite frankly. But if that baby is having trouble breathing, if they're breathing slow, if they're having seizures, what any number of things that may be, that would be an indication normally. That medical indication won't change. But to test everyone, no, that was both unnecessary and probably against their rights.
So we do have a kind of, it's not mandatory, but it's a genetic blood testing of all newborns to make sure they don't have any, they won't have any genetic issues. And I think we're one of 3 states that can still opt out with religious or exemptions, but I'm not sure if you know, but I'm basically asking for people behind you, if they can't catch those, any substance abuse use disorder as part of the check on genetics. But if you know those, Senator Baldwin.
I don't know the statute, but I can tell you, that wouldn't be something that's checked. It would not be a test that's done.
Representative Ward, one more, go ahead.
Thank you, Mr. Chairman. Supposing the parents are the type of parents who don't want certain interventions on their newborn. For example, they don't want the ointment on the kiddo's eyes because they think it's unnecessary, or they don't want the vitamin K shot because they think it's unnecessary. Could this be construed to cause a problem for those parents not wanting those types of interventions? In other words, the care team might say, well, you have to have these interventions, so we're going to make them make the newborn have them.
Go ahead, Senator Baldwin.
Thank you, Mr. Chairman. I apologize for my voice. I don't believe that this is considered a forced thing. I believe it's something that the parents could opt out of. If the provider or providers felt it was a dangerous situation, I think they could move forward with that just like they can now. But I don't think the plan of safe care is something that could be forced on anyone. I believe the parents could opt out.
Yep, go ahead, Representative Trio.
Thank you, Mr. Chair. On the patient care team, it says team of healthcare providers. Do the DFS social workers fall under that?
Senator Baldwin.
Thank you, Mr. Chairman. They would under this plan, they would be a part of the team if needed to be called in, yes. Initially, they're not the piece of the team, but they would be a piece of the team as it evolved.
Other questions for Senator Baldwin? Seeing none. Oh, you do, Representative Pornok, go ahead.
What happens now in these situations?
Senator Baldwin, if
Can
you
you
know.
repeat that question? I was coughing. I'm sorry.
What happens now in these situations when a infant, when a newborn where, you know, the mother has an addiction problem, or, I mean, what are we doing currently?
Senator Baldwin, if you know.
You know, and there again, DFS will talk to this more, but right now, too many of these people are being sent home. And I would refer the case that happened in my community. The two children actually that went home ended up in a horrific situation at a babysitter, which is part of another bill that came across, but ended up in the death of a child. There was nothing forcefully done. They weren't referred on. So a lot of these kids are just going back to that home or going into another home, and no plan of care is being done. And it's where a number of our infant deaths and where our problems with kids with disabilities are coming from. So right now, unfortunately, nothing is being done unless that caregiver senses that there's a dangerous situation. If I, as a caregiver, see this child and I think it's too dangerous a situation to send that child home, I would be making the phone call to DFS and saying, we got a problem here. I'd like you to look into it.
Yeah, so right now, then it seems like that connection with DFS is up to the healthcare provider. This bill makes that mandatory. You know, is that, could we go overboard with that? I mean, you know, a mother who's about to give birth, I'm not sure, doesn't always appear, you know, in her right mind, I suppose, or, you know, you could have somebody who comes in screaming or zoned out, or who knows what the situation is. So now it's required to, in this bill, it's required to contact DFS. I mean, are there potential issues with that?
Maybe if you could talk about what happens now, Senator Baldwin.
Mr. Chairman, and I guess the point I would make to that, and that's a good point, is that the difference is that now when that occurs, when I make that referral for DFS, for example, now, as it's more of an enforcement type gesture, as opposed to this will be a plan of safe care is the easy way to go back to it, but something that's not forced on mom. It's not something that's forceful, and DFS is not there in an enforcement capacity. There is an adjunct to help make that plan to help mom and the baby down the road in the future. So it's not as an enforcement feature. So that's a differentiation I would make.
Okay, you have a follow-up again?
Yeah, thanks, Mr. Chairman. Describe the safe care plan. Is there a template that they use, or do they have to come up with this new with every situation? Are they doing something like this currently, or is this something they come up with off the top of their head? Is there somebody who knows how to tailor these kind of plans to different scenarios? You know,
Senator Baldwin, if you
Mr.
want that, or
Chairman,
there's lots.
And we're going to pass this on to the DFS folks behind me because they can answer that more specifically.
All right, other questions, Senator Baldwin at this time, Representative Ward.
And thank you, Mr. Chairman. Just to follow up on Representative Hornock's questions, it does say on page 4, starting with line 17, if the patient care team identifies a safety concern for an infant, the patient care team shall make a mandatory report to the local child protective agency. So my question is, it seems to be quite mandatory here. Do I not understand that correctly?
Senator Baldwin, but
Mr.
that's
Mr.
the
Chairman,
current law now.
and that is current statute right now. That is, I am bound by that statute in Title 14. If I have a safety concern for any child in my office, in the ER, or in the delivery room, I'm required right now to report that. So it doesn't change that at all. That's already there.
We'll call some other people up, hang out if you'd like, or if you. Okay. Let's see, standard order of practice, Representative Bear, you want to testify on this bill? Okay, Governor's office, you'd be next if you're here, Ms. Davis. Welcome, Jim.
Good morning, Chairman and committee members. I'm Jen Davis. I am the Health and Human Services Policy Advisor for Governor Gordon. We are here today to stand in support of this bill. Our office has been engaged in these conversations over the last few years with the variety of agencies and stakeholders in developing this plan. As Governor Gordon has made clear, he is in very much support of supporting mothers, particularly those who are vulnerable and have addiction. So not only does this bill help support mothers, but it also helps support our vulnerable infants as well. As we know, the country has seen a growing trend in substance use. Addiction is a disease that needs proper care and support to ensure recovery. When addiction afflicts our new mothers, it's imperative that we have a means to ensure a referral for services during that very vulnerable time. Anyone who has been a parent or knows a parent knows that there's a lot of additional new stresses with a new baby going home. This bill ensures that our providers recognize the importance of supporting both moms and babies through this development of a plan of safe care. And as was mentioned earlier, this is a voluntary program. They will be identifying at birth, but again, the parents or the guardian of that child will have the opportunity to opt into these services, or they can opt out of these services at any point throughout here, unless there is a true safety concern, which they are already currently bound to do by statute, as was brought up a few minutes ago. So not only does this bill ensure that a conversation occurs and that referrals are made to support the mother through her recovery, it also ensures that the vulnerable newborns are monitored after discharge for any developmental changes. You'll see in the bill that there is a requirement that the child receive a referral to a child development center to monitor development over time. We know that infants who have been exposed through addiction can have a potential to have some developmental delays over time. And we want to be sure that these children are monitored over time. So that is part of the referral process in the bill that you have in front of you. Research is clear that substance abuse can have that impact clear up into the elementary ages. So it's vital that we ensure that we're monitoring these children. Our child development centers understand the importance of a stable family unit to ensure the best possible outcomes for our newborn infants. So the importance of this bill is not only for the children getting services through our child development centers, but the whole intent of our child development centers are to support families. So not only will they be looking at the infant, but they will also be supporting these families and ensuring that they're getting the referrals that they need as well. So once mothers leave the hospital, we often know that it's difficult then to connect them to resources, which is the whole intent of this bill, is to ensure that at the hospital for these newborn infants, and as was mentioned by Senator Baldwin, prenatal is in there as well, that we make sure that we catch these individuals when they are there and available to us to get them connected to resources. As all of us, once we leave many of those situations, life gets in the way, and sometimes then it's harder to come back into those services and referrals. So we want to ensure that these referrals are happening at the hospital before the moms and babies leave, which is the intent of the plan of safe care. So our goal is to keep families safe and help them prosper, but it also ensures that the safety of the infant is the priority. So the Department of Family Services is here today and will speak to this. But their whole intent is to keep families safe and keep them at home when possible. They have a program called Why Home Matters, which is about prevention. It's about how do we help these families before there is an issue where protective custody is necessary. And again, that's really the intent of this bill. How can we help these individuals before something elevates to a level where the baby needs to be taken into protective custody? However, also allows in the bill, as Representative Ward pointed out, does allow for and requires that continued mandated reporting. If you do see a safety or an imminent harm, then that does engage the Department of Family Services. Additionally, I just want to mention in the bill, there is a time for January of 2024 for implementation of this. That was intentional, as was mentioned. There is pilot projects occurring right now. And so that information will be utilized as they develop this program with the hospitals across the state to allow them time to make sure that, as Representative Hornock brought up, that the template and everything is secure and standardized so that everybody is addressing this in the same manner. So again, we support this bill, want to support our mothers and babies as much as possible in our state, and happy to stand for any questions that you all might have for me.
All right, thanks, Jen. Questions for the governor's office, Representative Hornock.
Thank you, Mr. Chairman. You mentioned that part of the goal with this is to possibly monitor children up through elementary school. Can you kind of explain that, what that involves?
Go ahead, Ms. Davis.
Chairman Zawanitzer, Representative Hornock, absolutely. So our child development centers, which are our Part C and Part B programs in the state, which is when infants are in the Part C program, which is 0 up to the age of 3, they can be served under what is considered medical opinion by the provider that is evaluating them, either PT, OT, speech, any of those professionals can allow that child to have eligibility in the program. If a developmental delay is detected, then that child becomes eligible under the qualifying criteria in our statute. And then those children would remain under care as long as they remain eligible, which could be up through kindergarten age and until they reach kindergarten. So this bill, by having infants referred to the child development centers, ensures that we're looking at those children developmentally over a period of time. And then parents, of course, can always bring children back in for a developmental screening at any time that is free to them. That's in our current statute.
Questions, Representative Klaus, and we'll go to Representative Ward.
Thank you, Mr. Chair. Thank you, Ms. Davis. Just page 2, line 19 says addressing the health and substance use treatment needs of the infant and the affected family or caregiver. So, you know, in my profession, some of the worst abuse I see is from fathers, and we haven't talked about the fathers yet. You know, whether they're exposing the kids to meth or other things, or they're physically abusive. On this line, is there also options to help the fathers?
Ms. Davis.
Chairman Zawanitzer and Representative Klauston, yes, the intent of the bill is for parents or guardians, which can include mothers, fathers, wherever there would need to be a referral, as we're looking for the overall safety of that family and that infant. So absolutely, the fathers are part of that team. And whoever might be the guardian also could be a foster parent, a foster father. Those would be included in this bill.
So before I go to Representative Ward, let me just double check on that statement. So the plan of safe care is ultimately about if there's a substance use disorder infringement on the infant. So when we're talking about the treatment needs of the infant, are those the treatment needs of the affected family or caregiver? Or are we going broader to things like, you know, abusive personality or Is it tailored narrowly to substance use disorders and seeking help for those, or is it tailored to a broader, safe environment for newborn who may have a substance use disorder to have an appropriate placement in care?
Representative Zawannitzer, I might refer some of that to Senator Baldwin. It is my understanding that part of the plan of safe care is that it is a comprehensive look at the child's needs for safety within that home environment. So it would include referrals for treatment, include referrals for mental health. Again, it is a mechanism for creating referrals for that. And again, voluntarily, of course, these families can refuse any of that if they so please, unless the child is taken into protective custody, which then moves to the whole other system.
Okay, Representative Ward, question on the bill.
Thank you, Mr. Chairman, and thank you, Ms. Davis, for being here to testify. My question is, and it might be more appropriate for Senator Baldwin, I'm not sure, but on page 4, letter D, it says, if applicable, a copy of the safe plan care shall be provided to the appropriate community partners. Who are those appropriate community partners?
Go ahead, Ms. Davis.
Chairman Zawannitzer, Representative Ward, I'll take a stab at this and have Senator Baldwin back me up if there's anything additional. It is my understanding in the bill that those applicable partners will be whoever those referrals are needing to be made to. So for instance, the Child Development Center for the infant, maybe an addiction specialist for the mother, should she agree to treatment. So anybody that they're making referrals to that the family agrees to, then they would have the opportunity. This allows us in this bill then to let the plan of safe care to be shared with them.
And if anybody else wants to follow up on that question later on, certainly do. Other questions of the governor's office? Seeing none. Thank you, Jen.
Thank you.
DFS, only become alphabetically, you come before Department of Health, so. But Department of Health, are you going to testify on this? You're not, okay. Welcome, Director, Ms. Schilling. Whichever one of you wants the floor, go ahead.
Good morning, Mr. Chairman, members of the committee. My name is Corin Schmidt. I'm the Director of the Department of Family Services. As I was kind of walking through all of the questions, I believe Ms. Davis answered a whole lot of them. So what I thought I would offer up is just a brief explanation of our abuse and neglect interventions, if that's okay. So there's a little bit of conversation about when DFS gets involved. So in this particular initiative, our hope is to not get involved. Our hope is that the family working with the care providers, working with the community resources, provides the opportunity for that child, that infant, to get the care that that infant needs, and also, if necessary, the care that the parents may need, whether it's substance abuse or mental health treatment. However, as Senator Baldwin mentioned, they do have a duty to report. So we have statutory mandate for mandatory reporting, of which we all fall under. If there is a reason that someone is suspectful of abuse or neglect, then a call must be made per the statute to the Department of Family Services. And then we make a determination whether the allegations, the report warrants us to get further involved, and then we'll get further involved if necessary. So mandatory reporters, we all are mandatory reporters. However, there's only 2 entities that can actually take protective custody: law enforcement and medical providers. The Department of Family Services cannot legally go in and remove a child. Although we accompany quite often law enforcement, or we are called to the care provider's office to provide consultation and support, we legally cannot take protective custody. So what that means is we work very closely with a lot of our partners in the event that there is some concern that the child cannot go home safely. If that's the case, protective custody is taken, and then we will take the child, place them in a foster care setting. And then after that, the legal process takes over, which is then involves the court and prosecution, et cetera. So as Ms. Davis had mentioned, we have really tried to develop a better and thorough understanding and support of prevention efforts. We believe children do best safe at home, and we think that they do best when they're with their family. Sometimes that might not be mom and dad, but oftentimes it does include relatives, grandparents, et cetera. But that idea about safe at home children deserving to be in a home is important to us. And therefore, we are really supporting a lot more efforts such as this, where we are hoping that we can connect, or the system can connect families with the resources they need so that we don't have to get involved and take kids into protective custody.
Questions for the Department of Family Services? Representative Hornock.
Thank you, Mr. Chairman. So I asked a question earlier, and can you elaborate on what a plan of safe care is? Do we have something like that now? Are there other states? Is there a template that we're going to use to develop this? Is this something that healthcare providers, when they hear that, oh, I know what to do with here? Or is it something that this is new? They're kind of starting from scratch on this. What is that exactly? Thanks.
Director, if you know.
Mr. Chairman, Representative Hornock, you'll be hearing, I believe, from probably a lot of the folks that are involved with this effort. But we have, in coordination with Department of Health, with local providers, with a pretty wide array of team members who have been looking at plans of safe care for some time. What this bill does is then give authority for the hospitals or the healthcare providers to engage. Part of that effort has included the development of a template. It's not ready yet, but it includes the development of a template that we'll have available by the time this law goes into place, if passed on January 1st of 2024. So the effort is underway, working voluntarily with a lot of the communities. And certainly I think you'll hear from them. As to how much do current providers know about this effort, that is part of the plan as well, is to engage through the Hospital Association and through other entities to be able to work with those providers so that they know when they hear or when they are come into contact with a substance exposed infant, that then they can use the language of we need a plan of safe care, and then everyone will respond accordingly. And I did want to clarify about the age. The legislation does say infant. So our anticipation, it would be some, early infant stages. If it's a child, that kind of takes a different path, but this is really looking at infants who whose family may need a lot more prevention, referral to services because of the newborn status or infant status.
Follow?
Yeah, thank you, Mr. Chairman. So you're developing the template now, and we don't have a law in place. So if this law does not go through the process and is something that's signed into law, do you see, will you continue that effort to develop that plan? And then essentially, I see that as something that would be not mandatory, but a possibility that you can offer to these families and in care for this infant if that service is desired. So, I mean, what does happen with the plan as it's going, as you're developing that safe care plan? What happens if this law isn't enacted?
Go ahead, Ms. Schmidt. I know it's not really your realm, but thoughts?
Mr. Chairman, Representative Hornock, we would continue working collaboratively. I think the difference about this piece of legislation is it gives some of the legal protection to the hospitals and the providers to be able to make those referrals. So it does give some idea to the hospitals. I mean, if they want to participate voluntarily, I think that's fine. But it also just gives a little bit more seriousness or dedication, that signal that the state is supporting this type of intervention, again, in response to a lot of the conversations the last couple of years around moms using.
One more.
Thanks, Mr. Chairman. Yeah, so there is a problem here. I can appreciate that. And I appreciate the foresight of the department to, take those steps to start something to help these important cases. But you said that there will be legal protection to hospitals and things to make referrals. Could you explain that? Is it something that once this is enacted into law, then you do the safe care plan, there's mandatory reporting and if on the off chance that, the healthcare providers got it wrong and it kind of is reported wrong, then there will be no recourse for that mother, that family in this situation. I'm just a little worried that might be a possibility.
Director Schmidt, if you want to comment on that, I'm sure the hospitals could say what they do now, but go ahead.
Mr. Chairman, Representative Hornock, legal protection may have been a little too much. It's really the permission or the idea that this would exist. In regard to doing it wrong, again, they're mandatory reporters. So if they suspect that there is something, a safety issue, they have to report. The Department of Family Services then makes the determination. So there is no legal liability for reporting, and that's covered under the mandatory reporting statutes. And again, this law or this statute is not about mandatory reporting. It's about engaging with the family, signaling to the hospitals, providers, healthcare providers that says, if you encounter a substance exposed infant, here is something that you can offer, and we're developing the system to respond to that. So then the hospitals, the healthcare providers then kind of know about a plan of safe care, a lot of it through this legislation, and then can make the appropriate referrals to those community connections.
Would it be fair to say this is what happens now if a child is taken into custody? You still have all those providers. You're just under legal frameworks to have to engage in all this. This would provide the maybe mandatory legal fiasco is where it comes to mind because I've had to do it. But this is a plan and you can still involve everybody without that kind of force of law and more expense and the judicial proceeding. Is that a fair way to characterize what a plan of safe care is? It'd be mandatory once a child's taken. This is doing all of those services and making all of these things available without having to go take the kid away and put it in foster care, but the child in foster care. Is that a fair way to assess it?
Mr. Chairman, yes, it is.
Other questions for the Department of Family Services? Seeing none yet. Thanks for being here. Department of Health still gonna get you up here eventually, Stephanie. Hospital Association. Welcome, Mr. Hannes.
Thank you, Mr. Chairman, members of the committee, Josh Hannes with the Wyoming Hospital Association. Just a few comments. One is we do stand in support of this legislation. Some of our member hospitals and myself have participated on that working group that was referenced, receiving technical assistance to put a framework in place to be able to execute on this legislation. Two of our hospitals have volunteered to participate in the pilot program that was mentioned as well. I believe it's Laramie, Ivinson and Laramie, and then Cheyenne Regional here locally. We just think that this is a good way to go about doing this kind of work prior to system involvement for mothers and children. Our hospitals are supportive. Our birthing hospitals are ready to participate. And I'm really here to hope to see this move forward and happy to answer questions.
Any questions for the Association of Hospitals? Representative Hornock.
Thanks, Mr. Chairman. I'm curious if you know how often this happens right now in throughout the state.
Mr. Hannes, if you have any numbers with you?
Mr. Chairman, Representative Hornock, how often what happens?
Well, yeah, Mr. Chairman, the cases of newborns that would fall under this developing a plan of safe care, I'm just curious how big of a problem, I guess, we have in Wyoming with this, if you know.
Sure.
Mr. Hannes.
Mr. Chairman, Representative Hornock, I do not. I believe the Department of Family Services could tell you how many cases are reported to them.
Can certainly bring them up in a second. Other questions, Mr. Hannah? Seeing none. Thank you, Josh. Ms. Sherrard or Wamsack? And then we'll get to probably Cheyenne Regional. I'm a Somerville.
Good
Welcome to
morning,
Labor
Mr.
Health.
Chairman. Committee members, Andy Somerville, Executive Director for the Wyoming Association of Mental Health and Substance Abuse. And we're here to support the bill as one of those community partners. So our community mental health centers provide the lion's share of residential, in fact, almost all residential substance abuse treatment in the state. That includes the only beds for what we call parenting women. They're either pregnant or they have very young children that can come with them into substance use treatment. And of course, we also provide a variety of outpatient services for substance use and mental health alongside that. It is incredibly important, the earlier that we can identify that there might be an issue and refer them to the appropriate resources in a positive manner, in a positive light, that increases the odds of these women and these families being successful and receiving the treatment that they need and really supporting a better outcome across the spectrum. We're happy to participate in the Plans of Safe Care group. And Mr. Chairman, I'd be happy to stand for any questions, but we do support the bill.
Questions for the Wyoming Association of Mental Health and Substance Abuse
Centers. Got it.
Seeing none. Thanks.
Thank you.
All right. Cheyenne Regional. Ms. McKinney. And anyone else you'd like to bring with you? There's 3 seats. Welcome.
Good morning, Chairman Wanitzer and committee. My name is Erin McKinney, and I serve as the Director for Women and Children Services at Cheyenne Regional, just across the street. My entire professional experience has been in women and children's. I've worked at the hospital for 22 years. So I've had a lot of experience with moms that have been using substances as well as babies exposed to substances. And so some of the questions that have come up, I'd be happy to answer as well. So I think what is really exciting about the state of Wyoming is last year there was a focus on criminalizing women that were using substances, and there's a complete shift in supporting our moms and babies to make sure that they have the resources that they need. And I think about bundling our babies and moms together. This is really bundling them with rich multidisciplinary teams to support them. I've been on the Plans of Safe Care Committee for the state since it started about 2 years ago. So a lot of work has been done here with stakeholders throughout the state. In 2016, federal legislation requires hospitals to implement Plans of Safe Care. So there's already a lot of states that are doing it really, really well. And so when you had questions about, are we going to be just making this up as we go? No, we have frameworks of best practices that we will be using. Questions about how moms are identified is the best practice is universal verbal screening of our moms, whether they self-identify or if they, depending on how they answer their questions, will go on to further screenings. So all moms, it's best practice that they're verbally screened, and we are too. So it's not doing lab tests without them knowing that this is happening. In terms of identifying babies that have been using, that have been substance exposed, there's screening tools for babies that they very clearly have withdrawal symptoms that help point the providers into a way that can help them go through their immediate time after delivery. The part of what we do see is moms who have used substances. Maybe they have a history of this and they have other children that have been taken into protective custody. Sometimes they don't come and get prenatal care and they just come to the hospital and then sometimes might leave because they're fearful. The judgment has been there. I think Karen's probably going to talk about this, but they don't intentionally want to harm their babies. This is an addiction. And the Plans of Safe Care that started with the federal legislation was in response to the opioid crisis here in the United States. The patients that we see often in Laramie County, as well as in the rest of the state, are methamphetamine, heroin. We are starting to see more fentanyl. So it's definitely a big deal. And I think you had the question about how many babies are exposed, or do we have records of that? And the last that I had seen for Medicaid was 143 babies that had been exposed. And this is important work. There's already a lot of discipline, like I said, a lot of groups that are working on this together. The focus has been DFS and public health working on this. So it's not just a DFS, referral and the baby goes into protective custody. There's an approach that there's training and an understanding of what this would entail and the different roles that each department or group that this patient might touch them during their pregnancy, postpartum, up through their first year. I'm not sure if I mentioned this already, but Laramie County and Albany County. So here we are the pilot groups. We'll be starting this soon, where when moms or babies are identified, that we can get them on the right path. And like I said previously, bundle our babies and moms together. And it is a best practice. So, thank you.
Yeah, I guess we'll hear from all three of you if you had anything to add, or we'll just throw questions at you, your choice. Go ahead. Just state your name and who you're with for the record, and floor is yours.
My name is Karen Miller. I'm a peer specialist. Chairman. I'm in favor of this bill because, being a person in long-term recovery and with lived experience with this, I am here to represent the fact that recovery is possible. And if we can help our families, your families, to be able to have comfort in reaching out for recovery and accessing it sooner without shame and fear of reprisal possibly, at an earlier stage, keeping them together, I think the success rates will be higher to be able to take accountability faster. The outcomes, it's generally proven that families do better sooner. I am also part of that pilot program of the Plan of Safe Care. And so I think as we have a wraparound for our families to be able to do this, it's a good thing to, sorry, it's Monday, God. To be able to encourage our families, to encourage our moms, to be able to catch this early. I've been in recovery about 17 years. And when I was able to feel like I wasn't judged and looked down upon, because this happens to anyone, I didn't exactly have a real history of it in my family. Dad was a little, but, and just to be able to have somebody in my corner. Okay. So that's what I have right now. And I hope that you guys will consider this. I'll take questions. Thanks.
Double check, ma'am, as well. Welcome.
Good morning. My name is Lana Mahoney. I'm a woman in long-term recovery from substance use disorder. I'm also a certified peer specialist with forensic and mastery endorsements, and I'm currently the executive director of Recover Wyoming, which is Wyoming's statewide recovery community organization. But today I'm speaking on behalf of a parent in recovery. And I wrote down a few notes. So as a young parent struggling with substance use disorder, I was really afraid and ashamed to reach out for help. Not only due to that shame and stigma, but because I was afraid I would get my children taken away. One of the most cherished roles in my life is being a mom. I can't imagine a life without my children. I've always just had like an innate desire to provide the best love and care for my kiddos. despite the fact that I once suffered from addiction. However, I was lucky in my journey, in my personal journey, that I did find recovery. I've been in long-term recovery for over 11 years. And my recovery was successful in part due to the wraparound services and collaborations of my support systems and providers, as well as the peer-based recovery support services that I received. Plans of safe care address the health and safety both of the infant and the parents, and providing substance use treatment and recovery supports to parents helps to heal not only the parent, but the family unit as a whole. It keeps our families together. It also results in healthier families, which results in healthier communities. Legislation that values the health and wellness of the parents and children helps to reduce stigma and shame associated with the disease of addiction and helps to heal our families. And that's why I'm in support of Senate File 79. Thank you.
All right, questions for either Cheyenne Regional or Recover Wyoming? Representative Ward, why don't you go first?
Thank you, Mr. Chairman. So it sounds like there's nothing that precludes the system from doing this now. Is that correct?
Ms. McKinney? Or maybe if you go through the process now on what happens and the choice you have to make, I'm guessing, of whether to call DFS and just go through when you see one of these cases, what's the current and what would change under this bill?
Thank you, Chairman Swanser, Representative Ward. So this is, we are, like, as many people have talked about, the mandatory reporting. And so what happens now is if a mom arrives to our hospital and it shows signs and symptoms of being under the influence, or depending on her screening, the mom, after she delivers, baby then is goes into the nursery, and is where a lot of the screenings then happen to with the baby. And depending on what kind of withdrawal that they might be doing, there's our pediatricians, and there was one that was trying to get on the line, but she had a sick child, that they will make a report. So it's the physician that can make a report, or the police department. So oftentimes our pediatricians will call the police department and make that report. And then based off from there, based on what their assessment is, the baby could be taken into protective custody. Now, there might be an opportunity where, based on the assessment with DFS and law enforcement, that babies can go with a family member, which is always what they try to do, or they go home with dad if that is seemed. He had a question about with safe and maybe whether he uses or in his recovery. And so really it is a legal route that happens majority, 90% of the time, that this is a legal route rather than supporting our moms and babies through other community entities.
Representative Clausen?
Yeah, thank you, Mr. Chair. I just wanted to clarify, we keep talking about methamphetamines and opioids and that kind of thing, fetal alcohol syndrome costs our country $4 billion a year. No one's mentioned alcohol substance abuse. I just want to make sure that's covered in this.
It is, yep. Oh, yes. Yes, it is covered in the plan as stated.
So what do you think the legislation changes from what is practiced now, Ms. McKinney? So if you had this, you would still likely call DFS, or if you would encourage people to say, we're not here to, prosecute you, we're here to do everything we can. I mean, just give me the scenario of what the expected change in the benefit is in your mind.
Sure, Chair Sponsor and members of the committee. So in my mind and with the team that I've been on with the steering committee, is that while some facilities might be doing maybe really well at following a plans of safe care without realizing they're following plans of safe care, that other facilities might not. And I've been in contact with other hospitals in the state as we're inquiring about current practices. And there's been hospitals that they've said that they haven't seen any patients with substance use. And then we can say, as I talked with them, they don't do universal verbal screening. And so they're the babies that are slipping through through the cracks, and the moms are slipping through the cracks as well. So what we would like to see is that the true pathway of who is contacted, what kind of services can help support our families. As Jen Davis had mentioned about the child development here in Cheyenne, we have Stride. And so it's early, really when the baby is in the hospital, it is already sending that referral to Stride. And so it's helping kind of to web out to the other agencies which aren't captured. And I think through all of this work, we have identified physicians that are MAT trained. It means that they can medically prescribe with moms that are going through their recovery to help them stay with it. And then after they've delivered and follow them through. So there's a lot of pockets that we've through this work found in the state that I don't think that we would have known beforehand. So that's been really good efforts with all of the state. And then, like I said before too, this is a total shift in what was presented last year here in the legislature with being criminalized, women criminalizing, and rather here we have identifying that this is a problem and what can the state do.
Okay, other questions for Representative Hornock?
Thank you, Mr. Chairman. You mentioned this, but I'm not sure if you know the answer, but you said that currently when this does happen, the police are called in some situations, in some circumstances. Nothing in this bill requires the police to be called. It's now going to DFS or another agency. Is that potentially a problem, a gap, or is that the right way to go? I'm just worried about the police actually, because of this, being left out when maybe they should be called and at times. Thanks.
Ms. McKinney.
Thank you. A part of the work group is law enforcement, and because they are an essential piece to this. And I think just in general with the population of women that are using substances is that the stigma and judgment that comes in. I mean, it happens, frontline. It can happen in hospitals. It can happen, in clinics. And law enforcement is not any different than that. And so providing the education to the touch points of our patients. And so with the law enforcement being a part of that is they could help also in helping to determine what that plan of safe care also could look like, because it's multidisciplinary. And do they have other children in protective custody? This is something that they would want law enforcement to be a part of. So the state committee is working on that, bringing in the law enforcement to be a part of it because it's essential piece for our families.
Okay. Other questions? Seeing none. Thank you all so much for being here today. Anyone else here to testify on this bill? Anybody online? Okay. We'll give it just a second. If anybody online wants to testify, feel free to raise your hand. Double check the room one more time. Not seeing any. Senator Baldwin, any closing comments? Okay, we'll close public comment on Senate File 79. Committee, what's your pleasure? Moved by Chadwick, seconded by Clouston. Discussion amendments. Representative Hornock.
Thank you, Mr. Chairman. So I'd like to get a little bit of more clarification. Page 3, bottom of the page, paragraph C. If the language is important to keep in there that talks about prenatal drug exposure and the medication that the mother's been prescribed by the healthcare provider. So I'm curious to get a little bit more information on that. I'm wondering if because I think in the emails that I've seen, people are a little bit nervous about that language, and maybe just striking that section may help, because we're talking about mothers that dealing with substance abuse, not necessarily medications. So that's, I want to make sure to get this right. This is pretty important. I don't know if that language in there enhances or adds or kind of what the point is to that particular section. I'm curious to get a little bit more information on that.
Well, it does seem interesting. The definition of plan of safe care, it's substance use exposure, doesn't say substance abuse exposure. So whether or not the infant prenatal or not had any exposure to a substance, and then you're going over and saying maybe it was a prescribed substance. I'm sure there must be some meds out there. I'm sure Dr. Baldwin could tell us. But then it says, well, yes, I mean, the kid has a substance use positive test, but it's nothing that needs to be treated. I mean, I don't understand why, but I think the language makes sense that it's some kids have a substance in their bloodstream for whatever reason that could be legitimately prescribed by a healthcare provider. And maybe Senator, if you'd like to come. And then you have a quick health screen and it says, we understand that, but there's no future risk of harm. Do you know why all that language is in there, how it is?
Yeah, thank you, Mr. Chairman. And that language, Representative Hornock, is there because there's a number of medications. Number one, that the mother is given as part of the delivery process. And I'm just going to throw fentanyl out there because everybody's talking about fentanyl. And that then affects the baby initially right then and there, as well as perhaps for the next few weeks. And this doesn't say, yeah, we're going to turn them into the police or anything like that. It just means when we do that plan of safe care, there's something to watch for in that child to make sure that that child then successfully, is able to wean away from the fentanyl. And I would give it as an example, other medications the mother may have been taking for years and years that have been prescribed to her, which then have an effect on the child. It's not necessarily a substance abuse, but it's a substance use, the medication that was prescribed by her provider that we just need to watch and make sure the child then is able to adapt and be able to, that child then does not develop a dependence on that drug, that the mother will probably continue using as part of her medical regimen down the road after that delivery. And I think that this language was a method of just putting that all in and making sure that we include that the child may have a problem from that drug, but mom wasn't necessarily, addicted to something. She didn't have a substance abuse disorder. It was a legitimate use of a medicine that was prescribed. And there's a number of medicines out there. And unfortunately, I would just throw in that a number of the drug dependents, and we'd have to go back to the WAMSAC, but a number of the overdoses, a number of the substance abuse begin with prescribed drugs, particularly with prescribed painkillers. You'll notice that Wyoming is part of a settlement in the opioid abuse, in particular oxycodone and OxyContin, which are prescribed drugs. They're useful. They have a place. Fentanyl is useful and has a place. Nonetheless, it does constitute a problem down the road for the child that child then has to be weaned away from. And the patient, the mom or the patient, if you with a broken leg go in, it's got to be given appropriately. So that's the intent of this, is the drugs that are prescribed legitimately, that we're able then to protect the child and wean them away.
Thank you. All right, other discussion of the bill. Representative Hornock, more?
Yeah, if I could just follow up with that, Mr. Chairman. It would seem like adding that language adds a ton more reporting on this. So you give a mother an epidural during pregnancy and then it triggers the requirement to do this safe care plan type of thing, or I'm going to the extreme in that example, but when we certainly want to target substance abuse, known substance abuse and issues that babies can have with a mother who is addicted to a controlled substance. That's our target group. So I have mixed feelings about adding that when we're certainly trying to target a certain problem that is out there. I'm just curious if that language is still is needed.
I guess that's a question for you, Senator Baldwin.
Mr.
if you have
Chairman,
thoughts.
I'll just go ahead and throw in it. I don't necessarily think it's about that language is a reason to throw that patient into this program. I think that that's part of the language that's needed for that provider or that provider care team to then say, yeah, this is something that's going on, but does it necessitate further action? And I think that leaves it to the provider and provider group prerogative to say, there's no need to address this. But if they don't do that and they don't at least look at it, then there's potential for a problem down the road. So to me, the language is important. But I'm not on your committee. That's your prerogative.
All right, thank you, Senator Baldwin. All right, other discussion on the bill committee, Representative Trujillo.
I don't know if this, how to, I believe this could be an amendment to the bill. Only for the reason that we always have the numbers, right? It says right here in on page 4, section 11, or section E, lines 11 through 16, on the reporting and totaling of numbers of infants and families whose plan of safe care has been developed. I'd like to add right after developed and the number of cases that don't accept help. Right? Because I'd like to know if they reached out to 200 women and only 25 accepted help.
So committee, I think would be somewhere on 13 after plan of safe care has been developed. You want it, and how many either went on to,
Yeah, like, you know what I'm trying,
I know exactly. Let me check with Ms. McKinney real quick. Would you, as part of that report, would that report automatically include the number of families who said, thanks for doing it, but we're leaving and not implementing? No, you can just shake your head. Come on up if it's gonna be more than a 2-word answer, then yeah, I guess come up. My general question is, if part of the report would already showcase that, but if not, maybe if you talk through how this works, we could get an amendment figured out. Go ahead.
Okay, thank you. So part of the report from the hospital perspective, that is just such the acute time that in just a moment in time that we have care for our moms and our babies. So I don't know that what the best practice is on reporting moms who might not be accepting. And, you know, they might not be at a space where they want to go into recovery, or there might be that time when they do accept and are engaged in the services, but then at some point might stop. And so from our work, it hasn't been that our moms would not reporting what our moms.
Does a plan of safe care terminate when you say, hey, we've developed the plan, and then 3 months later you come and say the plan has been finalized, we're done?
So a part of this with the collaborative that we'll have our monthly meetings with the specific stakeholders, which will include DFS, which will include law enforcement, public health. And at those times, the cases will be reviewed to see what the progress is. There's already case reviews that happen with children that are been abused children. And so I think it's at Safe Harbor. And so there would be ongoing connections. With the public health is the making sure that the moms are, seeking their treatment. They will be having touch points and going to their moms' houses. I mean, those kind of the different ways to check in and see how they're doing and meeting their recovery. So there is a part of that where they'll be engaged in their own recovery.
So Representative Trujillo, I'm just guessing your amendment up would be on page 4, line 13, after it says for whom a plan of safe care has been developed, and insert and the number utilized to the Department of Family Services. Would that cover what you're thinking?
What I'm thinking is if you refer Jane to DFS, does Jane accept the help? If you refer Susan to DFS, does Susan accept the help? So then there has to be a number that you're sending 200 women to DFS, and out of those 200, how many accepted the help and are continuing the help?
don't know that I'm the best one to answer
That, that's the
question.
question, because,
Yeah.
I mean, to get an understanding that the system is working.
Yeah.
Yeah, we can insert 200 people every year, but out of those 200, how many are actually accepting the help? And, then from there, why not?
Mhm.
Well, and then I guess, Ms. McKinney, my thought would be you develop this plan of safe care, you say, we're going to work with you, and they say, heck no. Then at that point, does a mandatory reporting fall in saying, I don't believe this infant is, and might be an emergency situation, then you're forced to call the department.
Mhm.
That's what worries me. If they don't agree to the plan of safe care as a mandatory reporter, I think I would probably call DFS to be safe,
Mhm.
and the child would probably be taken away is what worries me. Would that be how you see it, or is there another intermediate step?
So based on the assessment with the, after the baby is delivered, let me go back to what can you repeat that?
I think we're trying to figure out the best way to ensure if we provide these services
Sure,
and
yeah.
this plan
Yeah.
to make sure it gets utilized. And so
Mhm.
the question is, if they don't agree to utilizing the plan, what are your options? And
Sure.
my thought is your option is probably to call DFS, and you have to make a decision whether or not this kid goes into custody.
Yeah.
But are there times where you say, hey, here's the best practice, we hope you do this, and they say, no, thanks, have a good day, and you just let them leave? Does that happen?
So with the plans, so it would be either law enforcement or the pediatrician, the physician who would place a child into protective custody. And a lot of that can see what happens when the mom immediately after delivery, and oftentimes if these children or these babies have been exposed, then they could have a couple of weeks in the NICU. And so, what is that bonding looking like? How engaged is she? If there's ever a concern, and the plan of safe care does say this, if there's a concern of immediate danger, then always there's a report that's done. And so in some circumstances, this child might not be going into, the DFS report, and rather the public health style or, public health method. So if there always could be a time when they don't want to, and that then would be taken into the law enforcement DFS of what they decide to do.
Does that help elucidate your question, Representative Trujillo? I kind of know where you're going. I just not sure.
I know
how
where you're going
well-
to, I'm just not sure. Yeah.
That's the problem.
Yeah.
Other discussion, comments, committee, Representative Chadwick.
Thank you, Mr. Chairman. So would it be fair to say that this information, whether the mother participates or doesn't participate, would be within the report? Then it would simply be a matter of delineating from that report whether the provider wants to make that apparent in the report or not. It would be basically up to the provider. Would that be a fair assumption?
Ms. McKinney?
Yes, that would be the provider and or law enforcement.
And I'm just
So then
guessing.
that would be a part of the path.
But on this is a mandatory reporting
Mhm.
federal government, I'm just guessing. So you're having to report the number of people this plan. And is it a template then, like a form you fill out?
So as part of the pilot group that Cheyenne Regional and then Ivanson and Laramie, is that there is an online de-identified report that would go through for internal for the tracking of this. And so that's one method. And then the report then through the public health and the DFS. So using the template. So like I said, we're part of the trialing pilot hospital, and that's what we have that we're working on.
Representative Ward.
Thank you, Mr. Chairman. I just don't, I'm not convinced. I've tried to be convinced that this is necessary, but it just feels like we're already doing this, and why do we need to add this law to the green books? I'm gonna be a no.
So question, this federal reporting under the Comprehensive Addiction Recovery Act, is that already required of you now with or without this bill? Do you know?
So we are required, everybody in this room is required mandatory reporters.
Oh, no, this part on 4, it's the patient care team shall report the number of infants and families for a plan of safe care has been developed. But it says pursuant to a federal act of 2016. But does that come under, you don't report any of these things now, correct?
Correct.
Okay. All right, other questions, committee? Representative Hornick.
Thank you, Mr. Chairman. I'd like some clarification on the effective dates in section 3, because it seems circular. Paragraph A versus paragraph B. Paragraph B refers back to paragraph A. Just kind of trying to wrap my head around that.
Sure. So on page 5, it basically says section 2 is effective immediately. So the Department of Health and DFS can promulgate rules and regs starting right now. But the program doesn't become effective until January 1st, 2024. It is kind of circular because it says sections 2 and 3. And so it makes itself effective, which is weird, but I understand that it is confusing, but it basically says the rules will be implemented right away. The actual subsection A of this chapter won't kick off till January 1st. But I read that too and had to think about it and track it in. Other questions, discussion committee? And DFS did, or certain people texted me and said they were going to look if there's an amendment that can fit on that reporting of the number of utilizations, the number of people who have denied that. They're going to go back through the rules and see if they can do a floor amendment if the bill passes to meet that need. With that, seeing no other questions or comments, committee, Marilyn, if you'd call the roll on Senate File 79. Thanks. Al.
Representative Chadwick. Representative Klauston.
Aye.
Representative Hornoff.
No.
Representative O'Hearn.
Aye.
Representative Penn cast an absentee vote of no. Excuse me. Representative Trujillo.
Aye.
Representative Ward.
No.
Representative Yin. Chairman Zwanitzer.
Senator Baldwin, have you checked in any of the other co-sponsors or am I carrying this one too? I'll check with Representative Oakley because I know this has been the ongoing, her kind of primary area. So I'll check, and if she doesn't, I will. With that committee, we probably won't start till 9 o'clock on Wednesday because of the governor's prayer breakfast. I know 3 of us are going to. And I've been told the speaker is sending out a bunch of bills today to this committee. So we'll see what he has in store for us for the rest of the week. With that,